What I want to try and do today is persuade you that sport and exercise science is more than some people might consider it. So sport and exercise science is not just about the sport science element of it. It's not just about performance. It opens up a huge array of different areas that you could potentially go into when you finish. And what I'm going to present today is some research we've been doing recently and very topically, looking at helping people to recover from long COVID. And the knowledge that this has given us has been able to be gained through the type of things you will learn through a sport and exercise science degree at Swansea University. So at Swansea, our aims of our sport and exercise science degree are to develop scientists who can actually apply their knowledge. So we aren't just about giving you a whole suite of information and leaving it there. We're about translating that to tangible and meaningful benefit, be that on the sports field or in a public health arena. To enable that, we ensure that all of our teaching is actually underpinned by research. So the stuff I'm going to present to you tonight would be in our degree program this year. We will be highlighting to students how we have achieved that research and how they could be involved in it when they finish their degrees as an academic route, if that's something of interest to them. And by taking this diverse approach, by concentrating on ensuring that people can practically apply these skills and translate them, we ensure that your employability is enhanced. And we also provide you with key links, be that to the sports organisations or to public health organisations where you might wish to pursue careers afterwards. So we are very much focused on ensuring that we're not just delivering content because it's conventionally what is delivered in a sport and exercise science degree. We've tried to target it all to be interesting, but also the most relevant to you going forwards. So this is our modules that you will have the choices from. In the first year, you don't have any choices. Those are compulsory modules. And then in year 2 and 3, you get to select from the range of modules you can see on the screen. Now, this isn't an open day talk. I'm not going to labour through every one of these modules and explain what they all have in them, but I just wanted to highlight a few here. These are really the ones that would be particularly relevant to the rest of the research content that I'm going to go on to talk about today. So this is where you would learn the knowledge, the skills, and the techniques that we have used in this project that's been running now for just over a year and is getting to the point of publication and has been widely picked up throughout the world, actually. So what am I talking about when I keep mentioning this research? So very topical is the topic of long COVID. I'm sure you've all heard a lot about it and are probably a little bit sick to death of it by now. But this is the notion that COVID isn't just an acute event. For some people, and it's becoming increasingly evident that it's a pretty large percentage of people, the symptoms and experiences of COVID don't go away very rapidly. For about 1 in 5 people, those symptoms can continue for up to 5 weeks. And for 1 in 10 people, they last for 12 weeks or more. But this data was obtained back in April time, and it's becoming increasingly clear that this 1 in 5 people who have symptoms for up to 5 weeks are clearly liable to become the people who have it for more than 12 weeks. They just haven't had it long enough to know that yet. So this is an extremely common and unfortunately debilitating condition. And one of the remarkable things about it, and one of the things that makes it so hard to recover from and to provide the appropriate rehabilitation strategies for, is that there seems to be absolutely no link between the severity of the acute bout of COVID and the occurrence of long COVID. So some people are experiencing COVID very severely. Obviously, some people have got to the extreme, as we know, of mortality. Others just experience it like a mild cold or flu. And there's everything between that spectrum. But regardless of where you are on that spectrum, it doesn't seem to be translating to whether or not you will experience long COVID. So even some of the people that are only having a cold or a little bit of a bad flu, some of those people have got the worst long COVID symptoms. And we're talking about people who are young, fit, healthy. Many of the people in our studies were previously high-level athletes, triathletes competing for their country, and they have been totally wiped out by long COVID. And I'll show you some quotes on that just here. So you can see these quotes are quite emotive. And this is the kind of information that, as a physiologist, I wouldn't necessarily go out of my way to collect. But when you start to read this information, these quotes, you think actually that is pretty powerful. So you've got quotes like, haven't made a cup of tea since March. This person was interviewed in October 2020. So that's nearly 6 months. They haven't been able to make a cup of tea. They couldn't even make the bed or fold some jumpers because it made them too breathless. People describe fear and anxiety of doing any kind of exertion because they are terrified that it will land them back in bed and unable to get up for a week again. And as I say, these are not the 70, 80, 90-year-olds. These are the young, fit, and previously healthy people who are now experiencing conditions that they never thought they would experience at that point in their life. And this is one of the joys of our sport and exercise science degree, is that we will give you the tools to do both elements of this. So you won't just come out of it as a physiologist, as much as I would say that's a great outcome. You will also come out of it with the ability and the knowledge to undertake qualitative research, which is what this is. So running interviews, running survey-based studies to gain some of that contextual factors that help explain some of the numbers that I like to play with in my time. Now, if we go back to long COVID a little bit, I mentioned there that a lot of the people's concerns were around breathlessness, and that has been reported to be the second most common symptom of long COVID. Now, there is a myriad of different symptoms, and this chart changes probably every day as different people experience different things, and they last for different periods of time, and they're not mutually exclusive. So you don't get shortness of breath, but none of the others. You might get 3 of them, you might get 5 of them, you might get all of them. It's totally variable, and as yet we have no explanation as to why. But given this commonness of shortness of breath, this is what we decided to focus on when we wanted to identify a rehabilitation strategy. And it's particularly important to try and resolve this shortness of breath because of the vicious cycle that goes with shortness of breath. So we know quite a lot from other respiratory diseases. We obviously don't know a huge amount, we know more now, but at the time we started this study, we didn't know a huge amount about COVID-19. But we do know quite a lot about things like asthma, cystic fibrosis, chronic obstructive pulmonary disease, the long list of chronic disease conditions. And what we know is that these disease conditions are typically associated with breathlessness, which you can see in the top left of this cycle over here. Now, one of the consequences of this breathlessness, as you can see if we go clockwise direction, is of reduced activity. So these people start to avoid activity. They avoid things that are going to exacerbate that breathlessness. And because they start to avoid activity, they start to experience social isolation. So perhaps they stop going to walk the dog and don't see the people that they would normally have seen walking the dog. Or maybe they no longer go to the supermarket or to work even potentially. They start losing out on those situations where they previously engaged with other people. A very common consequence of social isolation is poor mental health and conditions such as depression. This then leads to an exacerbation of breathlessness, and it also leads to deconditioning, which again exacerbates that breathlessness. The more deconditioned you are, a simple task suddenly takes more out of you, and you perceive that as a worsening of your disease, when in fact it could be a loss of fitness. Deconditioning leads to peripheral muscle dysfunction. You lose stability, you lose balance, you lose ability to walk up and down stairs. So you can see how very rapidly this can turn into quite severe and long-term disability. So if we can resolve that breathlessness and we can prevent this vicious cycle from becoming established, then it's going to improve people's recovery and also reduce the burden on the NHS. Because what we're now increasingly realizing is that we've all been so focused on the burden that COVID itself has put on the NHS. I'm saying NHS because I'm doing this from the UK, but on any health service. But what we're now becoming aware of is that it's not just about that acute phase. Likelihood is that long COVID is going to represent one of the greatest burdens on healthcare systems of modern times. So we have got to find rehabilitative strategies that actually work. And that's where we now need to be focusing our time in. Now, one of the reasons why breathlessness is such an issue, or has such significant effects, I should say, is because there are a huge number of different muscles involved in respiration. And this is something that you would touch on in your first year of a sport and exercise science degree at Swansea, and then we would build on in exercise physiology in the second year. So you can see there's numerous muscles that are involved in both inspiration and expiration. And as soon as you get multiple muscles that have to coordinate and have to work together in an integrated fashion to elicit an action, it can very easily become dysfunctional. It only takes one of those muscles to stop working in the way it was meant to, and then suddenly everything is out of order. It's discoordinated, and that can result in inefficient breaths and have all the consequences of dysfunction and deconditioning. And this has been well evidenced previously in research. So here you can see a nice study that was done back in the early 2000s, where they looked at what happened if you increased the work of the respiratory muscles or you decreased it. So if we start with the boxes on the left, you can see you've got two bars there. The one that says control is the normal situation. So that's this person working as they normally would with no change to the environment. And you can see the extent of the muscular fatigue on the y-axis. Now, what they did in their study was they then did two conditions. One where they reduced the amount of work that the respiratory muscles had to do by giving them an aid, by assisting them in the work to complete that exercise. And one where they made it harder for those respiratory muscles. So they made them work extra hard to achieve the same exercise. And if you look at the line that says work rate, you can see it says 292 for all four conditions. So this is totally matched. There's no differences in the work rate here. But what you can see is that when they made it easier for the respiratory muscles, then the amount of peripheral muscular fatigue significantly decreased. And conversely, when it was made harder for the respiratory muscles, then the amount of peripheral muscle fatigue increased. So again, this provides a really good rationale for why we need to resolve this breathlessness. We need to unload those respiratory muscles to prevent activities of daily living suddenly appearing much harder to these people. Now, the mechanism behind this perception of increased effort is one that involves the metabolic reflex, which is again something that we would go through in exercise physiology, where we would look at the feedback loops and how they actually go about eliciting responses to pain, discomfort, hot, cold, any kind of stimulus you can imagine. Is all done by very elegant and very well researched feedback loops. And we'll go through lots of examples of those to understand the underlying physiology. But effectively in this example, what you have is your respiratory muscles are working harder, they're getting fatigued, they increase the amount of waste metabolites they produce, they increase the amount of afferent discharge and electrical stimulation sent from them back up to the respiratory center in the brain, saying, hang on a second, we're getting pretty knackered here. You need to ease off. You can't keep doing this exercise because we can't sustain it. So the brain's response to that is to then send signals down to the effectors, in this instance, the muscles, and also all of the vascular components en route to those muscles. And it does that by increasing the sympathetic stimulation. Now, if you remember from your current AS levels or A levels, sympathetic stimulation causes your veins to contract. So it makes them smaller, which means less blood is going to get through to those exercising muscles. If less blood is getting through, it means less oxygen is getting to those muscles. If we have less oxygen, they can't do as much work because they're not producing the energy required to do that work. So you're going to get more fatigue and you're going to get an increased perception of pain because you're going to have to start working anaerobically. And that's when we start producing lactate, which is what makes your muscles hurt. So a very elegant system of feeding that information from your lungs to the muscles to restrict how much more activity you do. Now, the conventional approach to addressing this would have been one using a pulmonary rehabilitation program. The effectiveness of pulmonary rehabilitation has been well and truly shown in the evidence base. It worked for a range of different respiratory conditions, and it typically is a multi-component approach. So you've got education where you teach people about the disease that they have and what breathlessness is and how they can try and manage that breathlessness by different ways of breathing, and also the importance of nutrition and other lifestyle factors. That goes along to other components, one of which is mental well-being, so teaching them how to manage some of the disease components in terms of the stress, the fear, how to have relaxation techniques. But the central component perhaps is the exercise component. Now this is done typically for 6 weeks, 3 sessions a week and 2 hours per session. And it would be a mixed session involving cardio and strength training circuits. But this is typically done in person. in hospital and in group-based settings, which clearly is not ideally suited when we are trying to minimize person-to-person contact, when we're trying to minimize exercise in group formats, and when we're trying to minimize the burden on the NHS, requiring them to set up sessions 3 times a week per person for 2 hours. Well, if you refer back to that slide where I said how prevalent long COVID was, translating that to over 1 million people in the UK alone who have long COVID, there is no feasible way that traditional pulmonary rehabilitation programs could be offered to all of those 1 million people. So great in theory, but just not practical for this particular environment that we live in at the moment. So we started to reflect on some of the work that we have been doing previous to COVID, where we've been looking at the utility of respiratory muscle training. So the idea of, can we train the muscles involved in respiration, just like you would train your biceps or your quadriceps? And there's been quite a lot of work in this area, which has been quite controversial. Originally, it started off in a performance arena where people were trying to see, can we train the respiratory muscles to make people be able to perform better, swim faster, run faster, and so on? And the answer to that appears to be very much, it depends on what sport you're doing. So again, in exercise physiology, which is one of the modules that I lead, we look at where it does work and where it doesn't work, and we try and tease out why it might work. So why might it work for something like swimming when it doesn't work for something like running? I'm going to leave you thinking about that, and I can answer any questions on it at the end of the webinar. In terms of health, we know that it does have its place. It doesn't work for all conditions by any means. Obviously, it's more likely to work for respiratory conditions than any other. The idea being that perhaps those respiratory muscles have become deconditioned, and therefore by training them, we can make them stronger, fitter, more able to meet the demands of daily life. And there has been some evidence of this. So we've seen what we call clinically meaningful decreases in breathlessness. By clinically meaningful, you'll see that coming up a few more times. By clinically meaningful, what we mean is it actually translates to something perceivable by the patient, by the person with the respiratory disease. So it's not just a statistical difference between two means, it's actually that person feels better. We've seen that it improves his breathlessness, improves his functional capacity, and importantly, these translate to improvements in quality of life, which is probably one of the things that means the most to the people that are trying to do it, is they actually feel like their lives are better for having done respiratory muscle training. So on the back of all of this, we thought it was worth a go with long COVID, and we were very fortunate to get some funding from the Welsh Government to enable us to do it. So this is a video of the postdoc who actually ran this study, showing the type of maneuver that we're talking about. So I'll just play this in the background. So what you can see is what we're talking about is an inspiratory effort. So you can see he's breathing in as hard as he can, but it's not just that initial sharp inspiration, it's keeping breathing in for as long as you possibly can. So you can see he's been going now 15 seconds. You can see it on the screen there, coming towards the end. So this is a sustained effort. And that's really important as well. And it's what distinguishes the type of respiratory muscle training we did from many of the others, in that it's not just about that peak effort. Peak flows are important, but it's a bit like peak VO2, where they're probably not the most sensitive or the most important for functional capacity. The ability to keep breathing in and keep breathing in at a high force is what really makes walking up the stairs easier, not the ability to do one big breath at the start. So as I say, this was based on some previous work we did. This is just showing you some of the combined outputs from that in a condition called bronchiectasis, which is a condition typically experienced by older people, but is thought to demonstrate quite a few similarities to how long COVID is being presented. So you can see at the top, we've got some what we call quantitative data. So you can see the changes following 8 weeks of inspiratory muscle training in both the patients on the left of both graphs and their healthy matched controls on the right-hand side. And you can see there were meaningful increases in both of the parameters shown up there. MIP, the one on the left, is maximum inspiratory pressure, so that's kind of a respiratory strength. And this is sustained MIP, which is more the 15-second long breath that you just saw James, our postdoc, doing there. But these numbers are well and good. They're not really the most impressive changes you can see on these graphs. But if you then read the comments that go with it in these blue boxes, you start to think, well, maybe this is actually genuinely having some effect. So this is where I mean that the mixed methods approach that we will make sure you're comfortable with by the time you leave is very important. So the actual study that we did, we were very fortunate to start this quite early. It's the only study I've ever done where I've never struggled for recruitment. I've actually got a waiting list for us to restart it. So we recruited, well, we aimed to recruit 250 people. We've actually recruited 281 to account for dropout, which we randomized to the control and intervention group. 8 weeks later, during which time the intervention group received 3 sessions per week at 80% of their maximum capacity. We retested the participants, and those in the control group were then invited to take part in the intervention if they wanted, so it wasn't withheld from anyone. And that's quite an important ethical point of view. Again, that's something that's a little bit unique about sport science at Swansea, that we do have a fantastic ethics and integrity group who are literally world leading. So you will be challenged to think about some of the ethical components of the interventions that we like to run. So it causes a lot of debates. We always think, well, we can make you better by making you do this. And they come back and say, what happens if they don't want to do it? Maybe they're happy where they are. Why should we intervene? Why should we highlight that they aren't well? And they really challenge the way that you think. So it's a fantastic stream that we have to the degree at Swansea. So as you saw in the previous video, this is a type of inspiration that is sustained for as long as possible. And it's also done entirely remotely. So none of this study involved us having to see any of the participants. We conducted it entirely via Zoom. They trained at home on their own, and we were able to track how many sessions they did remotely via the cloud, where every single session was uploaded and every breath of every session was uploaded as well. And this is a real advance of technology. So again, just to labour another novelty of the sports science degree is that we are housed within the Faculty of Science and Engineering. We've got very strong links with the engineering departments within that, which has facilitated us having access to technology, which we would never normally have as a sport and exercise science community. So you imagine it actually works quite nicely in that they are great at developing things, but they don't necessarily have an application. We have a lot of applications, but we don't have the tools to address those applications. So you can have a wonderful conversation with some of the engineers, moan about this bit of kit that we can't get hold of or doesn't quite exist in the way you want. Everybody goes home, they come back the next day and say, oh, I knocked this up in my garage for you last night. And lo and behold, it's exactly what you needed. So this is another great opportunity that you have to see not just pure sport and exercise science, but all the ways in which it can feed into so many different areas, which makes you really employable when you come out. So during the study, we assessed breathlessness, as you can imagine. We took lots of measures of quality of life, perceptions of competence. Did they feel like they could do more now? We took some measures of physical activity. So were they actually doing more? Not just that they thought they were doing more. We took some attempts at fitness assessments. Obviously, this is home-based. These people were not very well. We weren't anywhere near them. So if anything went wrong, we were only able to call an ambulance. So we had to be careful what we did. But we did nonetheless use a submaximal home-based exercise test to estimate VO2 max, or maximum oxygen uptake. And we also did semi-structured interviews, as I've talked about a few times already, with those blue speech boxes to find out what their experience of long COVID had been, but also what they thought of the intervention and how it had or hadn't helped them. So if we get onto some of the more interesting stuff, what we found, this graph is actually quite simple when we boil it down. So this is a graph that shows the outcomes in terms of what effect the intervention had on how breathless they were. And it's got lots of different domains. So you can see there's 3 areas here, and then the overall score is shown on the right-hand side. So this is questionnaire-based. This is self-perceptions. They come with their own biases, but it's also very important. And you can see that blue is the control condition and red is our intervention group. And you can see that regardless of which of these boxes we look in, the change in the intervention group was significantly more than the change in the control group. Now, the slightly good news is that there were changes in the control group. So it appears that some improvement of long COVID symptoms will occur over an 8-week period. So if we aren't able to roll out effective interventions, these people will very, very slowly move in the right direction. But inspiratory muscle training can exaggerate and accelerate that recovery. And if you remember at the start, I started talking about meaningful differences, clinically meaningful differences. For this particular test, we know what is considered the minimal clinically important difference. So we were able to say that the changes we saw in the control group were nearly twice those that were deemed clinically meaningful. Most techniques will only ever get to just qualify for clinically meaningfulness. So this is a fantastic outcome that really indicates this is a truly effective mechanism for those who receive it. Some more data on the breathlessness side of things. So this graph here is another breathlessness rating. You can see at baseline, which are these two here, the two groups were matched. So it's not just that our control group differed from our intervention at baseline, they were matched. And then over here, we have how much it changed. And again, you can see it's pretty much double in red than it is in blue. And again, it was twice the clinically important difference. These are all related to improvements in respiratory muscle strength. So we know that we did make those muscles stronger. And you can see that across a broad range of metrics, both the maximum inspiratory pressure and the sustained inspiratory pressure. And again, you can see there wasn't any change really in the control group. So this change is related to the intervention, and it's not just that people are getting better with time. One of the important things is whether or not these translated to functional and perceived differences. We saw that there was a 15% increase in estimated fitness over this 8-week period. If most people increased their maximum capacity by 15% in 8 weeks, they'd be pretty happy. So that's a fairly significant change. Obviously, we have to take it with a big pinch of salt because it is very indirect. They also perceived that they had got better. So we saw significant increases in their perception of their ability. But interestingly, none of these things meant that they actually moved around more. So according to the physical activity metrics, they didn't spend less time sitting down, they didn't spend less time moving around, and they didn't spend more time sleeping. There is a lot more analysis we need to do in that area, but the preliminary findings suggest that it didn't translate to changes in that. That could be because people had returned to work, so their time was not entirely free for them to actually change how much they were doing. And we got some very emotive, very meaningful quotes from this. So these are people's perceptions of how it helped them. People saying that they could do two to three more times more the amount of exercise they could do before they started. That they did find it extremely difficult, but they still think it was worth it overall. And that's the honest insight. This is what will help if we get to the point of trying to roll this out. It's not just us researchers, us academics saying, oh, it's marvelous, you should all go and do it. It's real people's experiences saying, actually, you know what, it was a bit of a pain, but I still managed it and it made me better in the long run. Or it's not for me, and these are the reasons why. That's what we need. That's the honest insight into research. So the next steps for this are to try and disseminate it. And this is one of the things, again, to relate this back more to some of your career choices. This is where there's a massive gap. It's all very well and good, all this research being done in universities across the world, but we need to get it out of universities. We need to get it to the people who are actually going to use it. Now, you could be one of the people that translates that information. You could be one of the people that gains it by doing the research, or you could be one of the people who implements that. Your sport and exercise science degree will ideally position you to do any one of those. So we're going to continue trying to drive the dissemination of this, as we would call it, and also try and get it rolled out on a national scale, actually try and get it implemented within the NHS. And this is where our next steps go. So if you do come to Swansea to do your sport and exercise degree, if I've managed to encourage you to take that step, then you will hopefully see this research happening next. And this is looking at whether or not we could use this to prevent people from getting long COVID. So we know long COVID isn't going away. People are continuing to get COVID, they're continuing to get long COVID. Maybe by offering inspiratory muscle training to a wider range of people who are at risk, we could prevent them from getting it in the first place. And you can see here two potential different outcomes depending if people had the rehabilitation or prehabilitation strategy or if they didn't. So the red is what might happen if they didn't have it. They would just continue along their increasingly poor outcome trajectory. If we could get to them in time, potentially we could be able to get them out of hospital if they've already been in, or prevent them from going in hospital in the first place. So to bring us to a conclusion, hopefully I've managed to persuade you that there's more to a sport and exercise science degree than just looking at footballers, rugby players and swimmers, that this is a very fruitful area to work in. and that there's a huge number of careers that you can take by pursuing this health-related angle that you will also gain the expertise to do through a sport and exercise science degree at Swansea University. So hopefully I've vaguely excited you at the prospect of coming. If you do have any questions, feel free to ask them now, or if you want to contact me after the webinar, my email and my Twitter are both on the page there. Thank you for listening, everyone.